Excellent. Okay, it's so nice to see everyone. Good morning. Happy Monday. I'm going to introduce myself and then let the rest of our team introduce themselves as we take you through this presentation, and really appreciate you being here. I am Lauren Oshman. I'm the program director for the Michigan Collaborative for Type 2 Diabetes. I'm a family doctor and my practice is in Chelsea, Michigan. And it has been my pleasure to lead this group. Thank you for joining us. So in terms of our agenda, we're going to talk about an overview of what MCT2D is. We really want you to have an understanding about why we're here, what our mission is, and how we operationalize quality improvement in type 2 diabetes. And then we're going to talk really specifically about how you participate and how we operationalize that in terms of activities, submissions, et cetera. And then we've plenty of time for questions at the end, and I assume that there will be some clarification questions. I'm going to do some of the presenting. Heidi Dietz, our co-director, is going to do some of the presenting, and then Jackie Rao, our program manager, will as well. We're going to start real basic, which is, what is a CQI? You may know of CQI as continuous quality improvement, but it also stands for our collaboratives. And this is collaborative quality initiative, a little bit different. And these are different statewide quality collaboratives that work on a variety of different topics, right? So they might be on a surgical topic or emergency room care. And all of the funding for this comes from Blue Cross Blue Shield. And I think that's because, as a major payer in the state, Blue Cross is highly invested in improving the quality of care for patients in the state of Michigan. It's a partnership with physicians, physician organizations, and hospitals. And so we're enrolling at the physician organization level and then meeting you all at the practices. And we rely on trusted data to drive change. And so if you think about this more from an operational perspective, different organizations provide support, a coordinating center, someone to answer all the phones and answer your questions. And that's happening at Michigan Medicine for this particular quality collaborative in diabetes. And the funding is coming from Blue Cross. And then we're having this operational relationship with your healthcare system across the state. The other important thing to appreciate is that CQIs enroll and act on all patients. And so even though Blue Cross is our sponsor and cares a lot about quality, we are here to make sure that every patient in your practice, whether they have no insurance, Medicaid, Medicare, or a private insurance plan, and every payer has access to change. And that means that our data infrastructure does not only work on a Blue Cross Blue Shield focus, it works on every patient in your practice. And what are those levers of change? We're looking at our data and identifying where we can improve, and then helping you with change management strategies. Here's a list of the different quality improvement collaboratives across the state. And you might see a little bit of a commonality here, that there's a lot of surgical work going on, and that is changing. And so you can see there's a quality collaborative focused on obstetrics, one focused on low back pain, one of the newer ones focused on suicide prevention. Lots and lots of work now happening more in the ambulatory space, and that's a little bit where we sit as MCT2D. How we're different from some of those traditional surgical quality improvement initiatives is that, they may be trying to focus on making a knee replacement slightly safer. They have this very small population of people undergoing surgeries, perhaps focusing on specialists, and typically enrolling that surgeon in their hospital center and using humans who take data out of a hospital chart to obtain data for their analysis. MCT2D has a huge patient population, right? So when you think about how many patients in the state of Michigan have diabetes, there's a lot of people. It's 10 to 13% of people in the state of Michigan. And it's focused both on primary care, also a little bit on specialty care, and we'll talk to you about that. And that enrolls at the physician organization level. So really thinking about ambulatory practice. And then I'll talk a little bit about how our data is obtained and how we use that to change. So we're going to take you a little bit through our journey. What are we and what have we become over the last 3 years, really, since our inception? And so, as I said, huge problem when we think about common chronic diseases. Over 37 million Americans are living with diabetes today, and then about 12.2 to 13%, depending on what year we're looking at, of adults in Michigan have diabetes, which is just about 1 million people. In this group is people who know they have diabetes, and then other people who have not come to their wellness visit with you and don't realize they have type 2 diabetes yet. And then thinking about almost 3 or 4 times as many people, about a third of the population has prediabetes and has not yet been diagnosed. So kind of lots of people in this gateway to potentially being affected by diabetes in the future. Why does Blue Cross care about this? Why do we care about this? When I think about hypertension, like not much has changed. When I think of diabetes, I feel like every day things are changing in our care of diabetes, and a really big concern, right, in terms of being that cardiovascular disease equivalent of high risk for heart disease, stroke, high blood pressure, complications, neuropathy, kidney disease, and eye damage. And so from a healthcare perspective and a prevention perspective, man, if we could prevent people from having diabetes, it would be both improved quality of life and savings for our healthcare system. And so thinking about equity and where we're going with MCT2D, we're really also thinking about which patient populations have a higher risk, both of diabetes and then complications, and less access to good preventive and chronic disease management. And that might be based on a racial or racism difference. That might be based on a disability. That might be based on a region and living in a rural area, not having access to high quality internet, not being able to use technology. So lots and lots of disparities in the diabetes world. You see Heidi and myself. Heidi, you may be wearing the same shirt as you were in this picture. You're
Nope, I'm not, but it looks similar.
Slightly different shirt, but so I am the program co-director, and I'll let Heidi introduce herself in a little bit. She is our co-director. I think what's really important about us having a pharmacist and clinical faculty member as a co-director is really understanding how much type 2 diabetes is a team sport, right? So thinking about how we at the coordinating center, you and your practices and your physician organization are putting together those teams to be able to best take care of people. And it's not just us. So I told you we're one of the CQIs that are kind of housed in terms of the coordinating and organization at the University of Michigan. But it really means that we have a huge team of people here to support you. Jackie and Jake are here on this call. They are our program manager and associate program managers. And then we have a huge emphasis on user-centered design and communications to make sure that we're providing you with tools and information that you can easily use. Rena is our dietitian, and so we employ a dietitian on site to make sure that we have expert advice and help for you about that piece of healthy diet. And then we have a huge infrastructure in terms of our data and website team in there here as well. We work with different content experts. So people who are really experts either in research, quality improvement, who spend their entire day thinking about these kinds of technical issues. And those folks are listed here. I'll just mention a couple of them by name. So Dr. Dina Grausda is an expert in low carb eating patterns for type 2 diabetes. Dr. Rodiga Papbusui is an endocrinologist, and she is an expert on type 1 and type 2 diabetes. Joyce Lee is an endocrinologist and an expert in informatics and so on. So we have lots of different people who kind of help us with cutting edge information. And then we have a couple of different nephrologists who work with us. So in our team, we focus on primary care, we focus on endocrinologists, and we focus on nephrologists, 3 specialties that really share in the care of patients with type 2 diabetes. Dr. Papbusui and Dr. Mizukami Stout are the endocrinologists that work with us. And then you can see our 3 nephrologists here. And so we work as a team together to make sure that we're all on the same page with our initiatives. So hopefully that was a helpful introduction. Who are we? How do you find us? Who's on our team? You are all part of the 28 physician organizations who are part of MCT2D, and each of those physician organizations enrolls different practices. And that has given us an infrastructure really that includes more than 300 practices and more than 1,000 physicians in Michigan. And then kind of in the center of all this, we put the patient. And so our patient advisory board, and all of you will be asked to identify any patients in your practices who might want to participate in our advisory board, are patients that meet together and give us feedback on what we should be focused on, how to make it patient-centered, reviewing all of our materials, et cetera. So how do we function? And I'm going to turn it over to Heidi to present these next few slides. We enroll at the physician organization level. Physician organizations reach out to practices and enroll practices. We together set different goals and metrics and design quality improvement goals that we think are going to really help us innovate and drive improvement in type 2 diabetes. We gather patient data, hopefully in a seamless way from you. And then Blue Cross Blue Shield has a separate relationship with you for meeting those metrics. In other words, you don't get money from me, you get money from that financial relationship with Blue Cross. So Heidi, I'll turn it back over to you. Do you want me to keep sharing or do you want to take over share?
I can take over share. Thank you, Lauren. Let me just make sure I am sharing the right screen. Can we all see?
We gotcha.
All right. Well, thank you. And I'm Heidi Dees. I'm, as Lauren said, the program co-director. I'm a clinical pharmacist in family medicine at Domino Farms Family Medicine. And then I also have a faculty appointment at the College of Pharmacy. So I'm very excited to kind of move into the heart of MCT2D, which is our three quality initiatives that we'll be focusing on. Let me see if I can move my slide. So here are the three. We're going to want to work on increasing guideline-directed prescribing, increase the use of CGMs, and support the recommendation of low-carb eating patterns for certain patients. So I'm going to dive into each of these just briefly. So I'm sure you are all very familiar with SGLT2s and GLP-1s and how they not only improve patients' blood sugar, but they've also demonstrated very positive outcomes in decreasing adverse cardiovascular events, slowing the progression of kidney disease, and then, of course, why they receive so much attention is their support of weight loss and decreasing insulin resistance while doing so. We also have cardiovascular trials that support decreased mortality. And if we compare this with insulin and sulfonylureas, we know that both of these med classes not only promote weight gain, but do not have any evidence to support cardiorenal benefits. And so, again, this is why we are focusing on guideline-directed care. Moving on to CGMs, I hope you have all either heard or seen the impact of CGMs have on our patients. So we want to promote their use because they offer real-time feedback on patients' lifestyle. They have alarms, so they keep our patients safe for hypoglycemia. And also because it improves patients' monitoring of their blood glucose, because I'm sure many of us that are clinicians have all heard, I don't want to poke my fingers anymore. And so if we can get them on a CGM, they start to see how various lifestyle factors impact their blood sugar. Not only this, but MCT2D continues to advocate. One of our main things, and one of the things I'm most passionate about, is advocating for expanded coverage amongst our payers. And, you know, it's not always easy. And so when we're faced with payer choices that may not be completely aligned with ours, we continue to work with payers to discuss evidence and try to continue to promote change in policy. Switching gears, traditionally when we've talked to patients about a diabetes diet, it's focused on low fat. And we all know that with low fat means carbohydrates go up. And in the traditional diet, there wasn't a distinguishing between fast-acting carbs and slow-acting carbs. We used to tell patients to use fast-acting carbs to manage postprandial crashes. And certainly this can lead to lows at night and then highs the following morning. So if we switch gears and when we focus on low carb eating patterns, we see, and again, this is really nice to have a CGM because then patients can see this, decrease the glucose variability that we see throughout the day because we are focusing on a lower amount of complex carbs if they're going to have it. With that, we see decreased hunger and cravings over time for those fast-acting carbs. Insulin requirements are decreased. And so oftentimes, this is how we get patients off insulin. Certainly, this is another reason why we want a CGM so that we can have alerts for any potential hypoglycemia. We do see weight loss, so just another avenue to support weight loss. And then trying to eliminate those fast acting usually very sugary, sweet carbs and focusing on the healthy, slow carbs that kind of maintain patients over time. Another thing about MCT2D is we are always here to help you, and we have many ways that we do so. And so I want to cover a couple of these topics that are listed here. In the past 2 years, we have put a ton of team effort into creating patient and clinician tools. And so several that are listed here focus on our low carb eating pattern. So we have websites, we have materials that you can print out, again, supporting you that if maybe you don't have a dietitian in your clinic, we are providing you with the tools that you can share with patients, and a fantastic website where patients can actually build their own plate and learn. Moving on, we do the same for medications and CGMs. And so here are a couple of resources that are near and dear to my heart as I helped in the creation of these. Can't take any credit for the beautiful designs. That's our design team. But trying to help you in getting this guideline-directed medication to your patients for an affordable way. And so whether it's making sure we know what medication is covered, or providing resources to patient assistance programs, but then also giving you guides to help understand what factors of a patient would allow them to be eligible for the patient assistance programs. So we go beyond printed materials. So we also offer virtual sessions with various experts. So in 2024, we have 10 events planned. And so these are typically over lunch, an hour long, you get CE. So just a great way to come together and learn, hopefully when you might have a minute to yourself. Oops, I didn't mean to move on. Yeah. And then upon joining, we have 3 videos, trainings amongst our 3 pillars or initiatives that focus in much greater detail that I just went over here. And then finally, we offer one-on-one consultations. So you can message us and meet with me if you'd like. You could message us and meet with Rena, our dietitian. We are constantly trying to not only have educational tools, but tools that can help you with things that happen in practice. So I'm sure we are all very familiar with the GLP shortage. And so again, this is a nice resource that we created just to try to help you. And then finally, we're a collaborative. So we love to highlight our members and have them share their best practices. So we try to incorporate you guys into as many agendas as we possibly can. So with that, I'm going to turn it back over to Lauren.
Awesome. Thank you so much, Heidi. Okay, so I'm back to desktop 2 and sharing. Excellent. I just really appreciate Heidi's overview of how we focused, and I think putting myself in the shoes of a new practice joining MCT2D, it seems like a lot. And I think what's important to appreciate is that this is all work that we co-created with participating practices from the beginning of the collaborative a few years ago. And so each of these tools was iterative in that they were asked for. We need help with patient assistance programs. We would like to learn more from you about how to integrate a pharmacist or how to help our dietitian learn new ways of talking to people. And it continues to be iterative. So one of the exciting things about the team that we built is that when you've got challenges, and they're common challenges in taking care of patients with type 2 diabetes, that we can work together. One small example of that is with advocacy. And so MCT2D has been really instrumental in trying to push our state Medicaid program to do more coverage of CGMs for patients with type 2 diabetes. So it's a really exciting opportunity to be part of a bigger group of people who really care about making patient care better. I'm going to switch over and talk a little bit about data and reporting. And this is just like a rolling screenshot to show you a little bit of the data that you will already have access to for your patient population. And so this data dashboard is an outreach dashboard. It's an opportunity for you to get data about patients in your practice and filter them, looking at patients perhaps who have an elevated BMI or are on multiple daily doses of insulin or who don't have a CGM, and use that data to think about how you might outreach or even do some comparison work. So you could develop a report and look at different providers and physicians in your practices, et cetera. We will also be sending reports to each of you, and we're trying to do that now on a semi-annual to quarterly basis, looking at how you're performing and comparing that across the collaborative. I think what's important to note is that we're still iterating this data, and if you've ever heard the analogy flying the plane while you're building it, it definitely pertains to MCT2D, as we're working with each of your physician organizations to figure out how you code data in your EHR, bringing that into our collaborative for all of your patients and segments, and then trying to analyze it. So that's a much more fun conversation that we can have over cocktails or bottled water in the evening. But suffice it to say that we have data for some, but not all of your patients, and it's continually improving. And we're also improving the time to delivery. So anytime there's a claim for service, there's some delay in getting that information so we can report it back to you. So we're trying to get that delay so that our data is fresh, so that it's within a couple of months of the last service. Looking at collaboration and thinking about how do we meet together and work together to learn, we have the state divided into regions. And most of this is because some of our challenges are regional. Some of the challenges in being a physician in the Thumb region are a little bit different than being in kind of the Detroit metro area. And so as we learn from each other, we learn more about kind of regional differences or even payer differences across the state. And some of this is because we do have regional meetings in the spring and the fall, and we ask that each practice send their clinical champion or someone representing their clinical champion. If you're on vacation, I don't expect you to attend. And so we're trying to make this like less than an hour-ish drive for each person. And it's only one day a year. So we are asking you to drive to meet with us for an evening and collaborate. And one of the most fun things about this group is making relationships with other people working on type 2 diabetes care. And so that's how our regional meeting structure works. And then we have a collaborative wide meeting, and this is really for the physician organization level. So the individuals who are driving change at the PO level will meet with us in June once for a state collaborative wide meeting. So I want to talk a little bit about when I say what's next, we asked our existing sites, what in addition to these kind of three pillars, which Heidi and I and the team are thinking about as areas that are important, are evidence-based, and yet there's a lag, right? A delay in implementation in primary care to what we want to work on next. And there's two big focuses that our practices told us that they want to focus on. And one is prediabetes. And so the way we're operationalizing this is imagining for someone who just got that diagnosis of type 2 diabetes, their A1C was 6.2 for a long time. They come back and it's suddenly 7.5. Their body is in an optimal position to do some metabolic change that when you look at people who've had diabetes for 5 to 10 years, that's not as effective. And so this idea of what I'm terming a metabolic reset, but if any of you have better brand names for this initiative, please let me know, is identifying those patients right at the point that they are diagnosed with diabetes and thinking about how can we help them avoid some consequences later on down the road. And that might be focused on this diabesity diagnosis where bariatric surgery might actually help them remit their diabetes for years to come. It may mean going on a very low carbohydrate eating plan, which is proven in prediabetes to reduce the onset, or a very low calorie eating plan. And there's robust randomized controlled data to support all of these. So this will be something that we're focusing on in the next year developing for you. And then the next piece is health equity. This is very, very important to us at MCT2D. But as you can imagine, we're building this great and robust data hub where I don't yet have all the data about patient self-identified race and ethnicity. We're working on getting data on food insecurity. We're working on getting data on transportation issues and using that to think about how we can action more robust work in the collaborative for health equity. So we're doing that in collaboration with some other organizations. I won't tell you much about M-Shield, but they're another collaborative initiative that really works on social determinants of health. And so we're partnering with other people who are experts in this area. So I'm going to go into a little bit more detail now about the data and the dashboard and what I alluded to before. What's the problem? The problem is that if I asked each of you to assign a staff member in your office to write down data and send it to me for type 2 diabetes, no one would ever want to join this collaborative. And so this is a very, very different way of relying on data management, and we're not going to be able to do data manual abstraction with this large population of patients. And so the new Michigan Data Hub allows us to collect data with minimal burden on you. And that means sending data electronically to what's called MyHIN, the Michigan Health Information Network, and then to an organization called the Michigan Data Collaborative, MDC, which helps us essentially process all that data and put it into a space where then we can create these dashboards. And so it is an iterative process, as I said, where we're building more and more data, and again, changing it over time as we figure out what we need now that's different than what we needed before. And so there were a couple of initial data elements that were very key to us, and this comes both from claims data and also data from your electronic health records. And that includes laboratory information. It includes prescription information, both for medications and technology, so for continuous glucose monitoring. It includes patient weight, height, BMI, blood pressure, et cetera. And then that demographic information, right? So not only gender, name, and date of birth, but also thinking about some of that other demographic information that helps us with social determinants of health and health equity. We receive this information from a couple of different ways, from claims, from clinical data from your practices, and then using that again to produce these dashboards that we send back to you. And we're using them in different ways, right? How are you doing in relation to the collaborative? Are there bright spots, practices that we can learn from who are doing something differently? And are there practices that are lagging and may need more education or focused quality improvement help? How do we use this data? We will share it with you at findings and ask you to help us interpret it. We will assess and find areas for improvement together. We develop different QI initiatives based on what we're seeing in the data, perhaps that our practices are lagging in checking both urine microalbumin or albumin level, and also a creatinine, which are both important. And so we want to do more work on making sure that we check those every year. And then we're rewarding. So we're moving kind of towards a value-based reimbursement or rewarding for practice improvement. So as I already showed you, we have different patient lists and summary measures. And then we're producing quarterly reports. And, you know, again, while we're increasing data over time, your feedback on this has been very, very helpful to let us know how to iterate. So in the spirit of quality improvement, we're doing it, and then we're changing it over time. We're improving it over time. And so we are using these both to give you some information to share amongst your PO and, you know, how we can reduce undesirable variability between practices and also what we're learning at the whole PO level. So I'm going to talk about participation and then turn it over to Jackie to talk about some more logistics. But right now we have 310 primary care practices, 21 endocrinology partners, 15 nephrology partners across the physician organizations. And as we talked about, we have organized these into different regions. You kind of see the number of practices that are amongst regions, and it makes sense, right? So population centers in the state and where most of our practices exist. And so I'm going to ask Jackie to take over, and we're going to talk about the participation requirements.
Thanks, Dr. Ashman. Hi, everyone. My name is Jackie. I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. And we'll go over some of the details of exactly what it means to participate as a primary care practice in the program, what the responsibilities are, what the time commitment is, et cetera. And then we will have time at the end for any questions that you have related to any component of the program so that we can get those all answered for you. So the practice organizations come down into 5 different areas: administrative, quality, attendance, data, and engagement. And I'll go through each of those in detail. As far as administrative requirements, really what we're asking is for you to indicate that you're interested in participating and to communicate that with your physician organization. As Dr. Ashman described a bit earlier, we really organize participation in MCT2D with the physician organization as a large support for their practices that enroll in the program. We would ask that you identify a practice clinical champion, and we'll go into some additional details on what that means and what those responsibilities are. We also ask that each practice identify a practice liaison who could be an office manager or other administrative staff who really just serves as an additional contact for the practice to help keep on track with requirements, or be another person that the PO or us can outreach to if we have questions. And then really just respond to questions and requests from both your physician organization and from us at MCT2D when asked. Their attendance requirements at the practice level is our MCT2D regional meetings that Dr. Oshman introduced. So these take place twice a year. We ask that the practice clinical champion attend those meetings. And for new sites, your participation in MCT2D begins September 1st, and we would ask you to attend those regional meetings for the first time in spring 2025, as opposed to the ones that we're hosting in the fall. We'll spend like this fall getting you kind of ramped up and ready to participate through the trainings that we have, through the practice change readiness assessment and other requirements. And then in spring, have you be full participants in the collaborative, including attending the regional meetings. For data, we ask that you share the required data elements with the Michigan Health Information Network. And so really that happens for the most part on an automated basis, like Dr. Oshman covered. So through the data that's gathered through the PPQC and claims, et cetera. But if there is data elements that are missing, that are ways that we can address them, we would ask you to partner with us to make sure that we're getting the data that we need. We want you to work with us to develop the ability to submit additional data elements, so social determinants of health data, remote patient monitoring data from CGMs, et cetera. Partner with our partner, the Michigan Data Collaborative, to help improve the data submission process as needed, so submission rate of needed data elements, distribute patient-reported outcome surveys, and allow data from the collaborative to be used in peer-reviewed publications to support the advancement of our QI efforts. For engagement, we ask that the clinical champions participate in those training programs that we highlighted on CGMs, low-carb diet, medication, and then using all those interventions together, as well as attend those regional meetings and take back the information from those meetings and share them with attendee or members of the practice who don't attend those. We also would ask that you identify patient advisors to serve on the MCT2D Patient Advisory Board. We try to keep the patients as a core component of the work that we're doing and make sure that we get their input on patient-focused tools that we create or the direction of the collaborative in general. So if you have a patient that's a good fit for that or who's interested in sharing their story or being part of that, letting us know so that we can work with them. And then distributing patient education and tools that are developed by the coordinating center to help support the implementation of these initiatives that we're working towards. And for quality, we ask that you commit to focusing on the MCT2D quality improvement initiatives, currently low-carb diet, CGM, and the medication prescribing. Implement best practice in collaboration with your physician organization using the feedback from MCT2D data and the collaborative. Sharing what your practice has accomplished with the collaborative through presenting at things like the regional meetings and participating on panels that we host, and then providing feedback and ideas for innovation in diabetes care quality so that we can together as a collaborative come up with ideas and choose what we want to focus on moving forward. As far as the requirements for the clinical champion role, so the clinical champion, first of all, just from an administrative standpoint of who can fill that role, we can have it be any clinical staff member at the practice. So it can be a physician, a care manager, a nurse, a pharmacist, a dietitian. We just want someone who's involved in clinical care and who can take back and disseminate the work at the collaborative with the other members of the office. They are the MCT2D lead at the practice level. We ask that they're the liaison between the physician organization, clinical champion, and the PO admin lead to disseminate information to others in the practices. So this involves things like, for example, we have our MCT2D learning community events that are just optional learning opportunities each month around a specific topic. For example, in March, we're hosting one on new updates to the ADA guidelines. And so we would email the practice clinical champion about those and expect the practice clinical champion to share that opportunity with others in the practice. You would also be serving as the PO's practice contact. You would be supporting and encouraging the practice on working on the MCT2D goals, completing the trainings on CGM, low-carb diet, and medication management, and attending the yearly regional meetings on behalf of the practice. Exactly like I just said, we'd ask you to share emails and information with other clinicians in your practice about the requirements, about our events that we host. We would ask that you follow up with participating practice physicians in your practice to ensure that they've met the MCT2D requirements. So a little bit later, we'll touch on our physician level and practice level learning community requirements that are referenced here. So making sure that those are complete for the practice. Giving feedback and input as requested from the collaborative. So we do sometimes do surveys or reach out and ask questions, and we would ask the clinical champion to give us information that will help us guide the direction of the collaborative. And then physician organizations typically have their own cadence of clinical champion meetings for their practices that are participating that they host separate from what we as a coordinating center do with the regional meetings. So those will take place on a monthly or quarterly basis, depending on your physician organization. So taking part in those as well. And like we've talked about, we have the regional meetings where we've divided the state into those 7 different regions. We have these in the spring, taking place in April and May, in the fall, taking place in October, November. These are 2 hours in person from 6 p.m. to 8 p.m. in the evening. And they're meant to provide an opportunity for the clinicians in each region to learn from each other, to collaborate, to talk about how interventions are being implemented at their practice and kind of share ideas, troubleshoot, et cetera. So that's the clinical champion role. Then each physician who's participating in MCT2D and earning the 5% value-based reimbursement for participating in the program has some expectations as well. So we expect all the participating physicians in MCT2D to incorporate the MCT2D pillars around guideline-directed medication prescribing, use of CGMs, and promotion of low-carb diet with their patients with type 2 diabetes. We are having participation-based measures for the initial year of participating in MCT2D, and then in future years of the collaborative, we will have performance-based measures that look at process changes and patient outcomes. So we do want all the physicians in the practice to be working on implementing these strategies so that that's reflected in the performance-based metrics that we'll eventually have. And we also have the physician level learning community requirement that we'll touch on when we talk now about value-based reimbursement. So each participating physician within MCT2D will earn a prospective, so that means as soon as your participation starts in MCT2D on September 1st, 5% value-based reimbursement payment for participation in the collaborative. And the way that that works is the 5% VBR is on all Blue Cross Blue Shield PPO members, so not just those with type 2 diabetes, but any patient from Blue Cross PPO that you're seeing, and then those are on certain codes, like typically E&M codes, vaccinations, et cetera, that you earn that 5% VBR. And these are the requirements that we have for the initial year of participation in MCT2D. So like I said on the last slide, they're starting out completely participation-based, and then in the future, they'll move towards performance-based measures. So we're asking you to identify that practice clinical champion and practice liaison that we said was a requirement for participating. We're asking the clinical champion to complete all of the MCT2D training sessions for the collaborative, attending the spring regional meetings in person, completing a practice change readiness assessment survey for the collaborative. So we have some questions that we'll distribute on like a 15-minute survey that asks about how your practice currently operates, your familiarity with QI, your familiarity with the MCT2D pillars, et cetera. Distributing a patient needs assessment and collecting a minimum of 10 responses per practice. So we want to understand like your patient's needs and what they want from their type 2 diabetes care, what resources and support they still feel like they need so that we can help you to provide that support as a collaborative. We're asking that you submit a report based on what you determine from that patient needs assessment. So where you see gaps and what goals your practice wants to address with that. We're going to ask each physician to complete a brief physician level survey that'll kind of be like a more granular version of that practice change readiness assessment where we're understanding what the needs are at the physician levels. And then participating in what we call our learning community events for each of the 3 different levels of engagement we have. So we have a physician level learning community requirement, a practice level, and a PO level. And for what we're asking each physician to do for that learning community requirement, we have different options for them. So it's not that they have to do all 4 of these different things on the screen right now. they can look and decide what makes the most sense for them to complete. And each of these has a relatively reasonable time commitment, needs to be done once a year. So we as MCT2D, like Heidi covered, create a lot of physician-focused tools, so decision aids, dosing guidelines, etc. If one of the physicians in your practices use those, we ask them to give feedback on them so that we can continue to refine that tool and make sure that it's useful and accurate. And so we, at a quarterly basis, look at all the feedback that we get from physicians on those tools and make edits to them to make them more useful. So submitting feedback on one of those physician-focused tools would meet that requirement. We have, and we've already alluded to, like our learning community events. So once a month, we host a learning community event based on a topic that the collaborative said that they're interested in. So like I mentioned, this month is on ADA updates. Last month, we had one on referral to specialists where we had an endocrinologist and a nephrologist presenting on when to refer, when not to, how to expedite referrals, et cetera. So attending one of those live, physicians both get CME for that, and it meets the learning community requirement. And then we have the second option. If they're unable to attend it live, we also have recordings of these learning community events. So watching a recorded version on their own time and submitting like a brief 5-question quiz just to demonstrate that it was actually viewed meets the learning community event requirement as well. We also have a program called our CGM User Experience Program, where we provide a CGM to try for the practice for free to get an understanding of like the patient's experience with CGM. We've gotten really good feedback on this from our providers of that it was useful. It helped them to understand the patient perspective on it, and it was interesting for them to be able to try and have that experience. So doing the user experience program, it also addresses that physician level learning community requirement. So physicians have from when the BBR year starts on September 1st all the way to June 1st to do any one of these 4 things in order to meet that. And the time requirement really ranges from maybe 15 minutes to review a tool to an hour to watch one of these events. So a lot of options there that hopefully fits into the physician's schedule. We also, for each practice, have practice level learning community requirements. So this just needs to be completed again once per practice per BBR year too. So we change and add to these throughout the year as well, like based on the focus of the collaborative and the work that we're doing. So ways that these can be met is submitting feedback on a patient-focused tool. So very similar to the physician-focused tool that we just covered on the previous slide, like being able to get a patient's input on one of the tools that are targeted to patients and sharing that with us so that we can make those more useful and better meeting the patient's needs meets it. And we have multiple other ways. We have user experience sessions on like our data dashboards or on our website so we can learn how they're being used and how we can make them better. We have a dot phrase library where EMR shortcuts can be added from across the collaborative. So sharing one that your practices use meets that. We have a best practice database where we've had our current collaborative members submit like best practices that they've developed around our initiatives, and reaching out to another practice to connect with them and discuss theirs meets that requirement. We also have partnered with the MShield CQI that Dr. Ashman mentioned earlier to do like one-on-one reviews of SDOH screeners so that they can be the most useful versions and capture like those main domains and getting feedback from the experts at MShield around that. So like the theme of these requirements in general is it's supposed to be something that either supports and helps the collaborative. So making sure that our tools are better, our website's useful to you, our dashboards are, that you're sharing things with other practices, and that you're providing opportunities for like your physicians to learn are really kind of the crux of what we're trying to get to with these requirements. So just to kind of give you an example of what those entail. And same as the other, just needs to be doing one. And then at the PO level requirement, similar to the practice one, these just need to be met once per PO. So as a practice, you don't really need to worry about this as much. Typically, the PO focuses on making sure this is met, but you as a practice can help your PO to meet that. So if your clinical champion, for example, participates as a panelist on one of our MCT2D learning community events, that meets the requirement for the entire PO. Same as like if someone from your practice wants to be interviewed by a member of our team to be part of like a blog or video about the work that's being done at your practice, how you're improving patient care, participating on the steering committee, or referring a patient for a patient story or to serve on the advisory board all meet those PO level requirements. So next steps as far as joining the collaborative, if you're interested in doing so. So what you would do is you'd let your physician organization know that you're interested in participating by April 18th at the absolute latest. Our recruitment closes April 19th. So I would suggest telling them before that, but that would be the last date that makes sense, as we're open for recruitment until then. They'll nominate you to join the collaborative. We're able to bring on 75 new sites this year. So depending on how many sites apply to join, if it's more than 75, we have some criteria that we're applying to evaluate who we should have join the collaborative. You'll be notified by May if you're selected to join. Then you'll have the summer to kind of get situated and ready to participate. So you'd be identifying the practice clinical champion, a practice liaison during that time. And then September 1st is when we consider your participation like truly starting. All the eligible physicians in your practice will begin earning that 5% prospective value-based reimbursement on September 1st. And then we would begin then with like the onboarding surveys and trainings and the work that we're asking you to do that we covered on the BBR requirements slide earlier. So starting September 1st through June 1st is when all of that work would be completed. And with that, we'll pause and see if anyone has any questions that we can answer. We'll distribute these slides as well so that you have access to them after the meeting. But does anyone have any questions at all about the collaborative in general, about the requirements, about the initiatives or the pillars that we're focusing on as MCT2D? You can either unmute yourself or type them in the chat.
As we wait for those chat messages or anyone to unmute, I think, Heidi, sometimes it's helpful for people to understand, why would they want to do this? Number one, we will reimburse you. There's value in attending, but I think that the main reason is that our practices really have enjoyed being part of this community and feeling like we're sharing best practices and helping you accelerate innovation. We've got something in the chat. Go ahead, Heidi.
Oh, I was going to add to that we have gotten feedback from our practices that participate in other CQIs and have said like no other CQI has provided them with the resources such that we provide, and also just feel so much a part of a community. So that's what I love to hear, that we have this community of advocates working to improve the lives of our patients.
So we got a question in the chat, where will the meetings be located? So our regional meetings are divided into 7 different locations across the state. And so what we do is, once a practice enrolls, we try to look at what meeting location is the closest for that practice. We try very hard to keep it within a 45-minute drive maximum for any practice, depending on the location. In like Southeast Michigan, we're able to achieve that fairly easily. The practices that are like very up north or like near Traverse City region, it's a little bit harder to keep it under that 45-minute drive, but we do try our best to do that. And depending on how many practices join this round, we may look at adding an 8th region so that we can keep the meetings smaller and continue to keep them as close as possible for each of the clinical champions. So we try to prioritize keeping those accessible by everyone, but just due to the spread outness of some of the up north sites, it's been a little more challenging there. But for the most part, it'll be less than 45 minutes from where your office is. Mm-hmm. Any other questions? Well, thank you everyone so much for joining. Like I said, we'll distribute these slides, and we also have recorded this meeting too. And so we'll post that on our YouTube channel and send that out as well if you want to review it later or share it with others in your practice who may not have been able to join but are interested in knowing more. So really appreciate you all being here, and thank you, Dr. Ashman and Dr. Dietz, as well for your presentation.
Thank you, everybody.
Thank you.
Bye-bye.